So today we have 3 presentations. Our first presentation is an update on the Wisconsin Tobacco Quitline services, and that will be followed by presentations from 2 tobacco cessation champions who have been instrumental in helping their health systems integrate electronic referrals to the Wisconsin Tobacco Quitline directly from their electronic health record. So I'm going to stop sharing, and it's now my pleasure to introduce our first presenter, Kate Kubinski. Kate has been with the UW Center for Tobacco Research and Intervention since 2007 as the Wisconsin Tobacco Quitline Coordinator. She manages the Quitline contract for the Wisconsin Department of Health Services. Kate, you can take it away.
And Kate, you are still muted.
Sorry, I couldn't get back to the screen to unmute myself after sharing my screen. Let me try that again. Okay, can everybody see the screen and hear me?
Yes, looks good, sounds good.
Okay. So thanks for having me. And as Allie had said, for this presentation, I'm going to review the standard Quitline services and provide updates on some of the new services that are recently available through the Quitline. And I do want to highlight up front what these new services are, and I will go into more detail in the presentation. But briefly, we recently added a new way to enroll in Quitline services called Text to Enroll. We have a new interactive texting program called Text to Quit, and this is for 18 to 24-year-olds. And then we have, I think one of the great additions to our suite of services is an American Indian program that offers more support. So just very quickly, some background on the Quitline. So Quitline services are funded by the Wisconsin Department of Health Services, as well as some supplemental funding from the CDC, and also we receive funding from federal research grants that we run. The contract for the state services is managed by the UW Center for Tobacco Research and Intervention, and we contract with a service provider called Optum, which is headquartered in Minneapolis, to actually deliver the Quitline services, and they have coaches actually all across the country. They're able to work remotely, so you know, in the last year with the COVID pandemic has not impacted their ability to deliver services at all because their coaches and intake specialists all work from home. So this year we actually hit our 20-year anniversary for Wisconsin Tobacco Quitline Services. It was launched in May of 2001. And since then we've received over 200,000 tobacco users have received services from the Quitline. And of course, as you know, the Quitline provides one-on-one telephone coaching, as well as mailed self-help materials, you know, directly to the caller's home, cessation medications, that's over-the-counter NRT, and a web-based tool, and I will go into more detail on those. And I think many of you also know that while the majority of residents who use the Quitline are tobacco users, I'd say 90%. The Quitline does also take calls from clinicians and proxy callers. Proxy callers are going to be family members of friends of tobacco users, and, you know, and they maybe want to learn how to offer more support or just learn more about the Quitline to share with their loved one. For clinicians, the Quitline has a dedicated small team of coaches who work with clinicians who just have treatments or questions about treating tobacco use. You know, whether it's about the use of medications or, you know, helping developing quit plans with their patients, and certainly just taking broad questions on the Quitline services in general. And of course, the counselors provide expert, individualized, tailored coaching. They receive hundreds of hours of training and continuing education. It's completely free to residents, confidential, and available 24/7. So we have 4 ways to access the quit line. The most common method, of course, is through the inbound call, people calling the national number, which is 1-800-QUIT-NOW. We also have a line dedicated for Spanish-speaking callers and a TTY line for people with hearing and speech difficulties. Sort of next after the inbound call in terms of the way people get in the most is a provider referral. And this is a direct line to the quit line, not just a verbal referral. So this will be a fax or an e-referral, and I'll talk more about that in a second. Web enrollment came, maybe within the last couple of years, where people can go to our website and there's a link there where you can basically register yourself online. And many people like that because they can, besides registering themselves, they get access, 24/7 access to the web feature, which, so they can engage completely online and they don't need to call anybody on the telephone. And then a new way is the text to enroll, which again, I'll talk about in a second. So with the provider referral, I briefly want to touch on this method. So the provider referral, the direct line to the quit line, is a treatment extender to the quit line. So it's meant to be the follow-up of, the treatment that you're delivering in the office. And the way it works is the provider is going to transmit a referral after the patient consents to the quit line, and this will happen either via a paper fax or an electronic referral. And then the intake specialists at the quit line are going to call the patient within about 3 days. That's when they'll make their first attempt. They'll make multiple attempts over the course of about a week. So they'll keep trying, and after about a week, the record closes. So specifically for fax referral, we've been doing this since 2003. This is paper faxing, a customized consent form to the quit line, and then the quit line is going to paper fax back an outcome report. Really, I think the gold standard is moving to the e-referral now, which is an EHR-based referral to the quit line. There's sort of a batch transmission of these e-referrals, and then the quit line will then electronically transmit those outcomes back to the patient's EHR record as a referral order result, and it's completely secure and HIPAA compliant exchange. Here's some information about the text enrollment. It really is as easy as it seems. The participant is just going to text the word ready to 200-400, and the quit line will text back 3 different questions. They're going to ask the person for their name, their zip code to identify state, because this is available across the country, and their permission to, when they call, to leave a message. And really that's as easy as it is. And then eventually a registration specialist is going to make the call to the participant, and if the participant is still interested at that point and eligible, they'll complete enrollment. And to date, we've had 29 people come in this way. I think there have been many more, textings to start the process, but actually getting through the entire process to enrollment, there have been 29 people. Here, I just wanted to share, I guess, snapshot, year to year of the quit line call volume since inception in May of 2001. So we've had over 300,000 total hits to the line. So not everybody that calls actually enrolls in services, but these, some maybe just general questions. But you can see quite a lot of variance here. 2008 was our highest year, obviously, at over 40,000 calls. That really was kind of an outlier. That was the year that the $1 cigarette tax went into effect in January, so during quitting season, and it was the first time that we began offering nicotine replacement therapy. And then other things that affect the volume include, I guess we've had other tax increases, the smoke-free air law, whether or not there's paid media, You know, the CDC has been running the TIPS ads campaigns since I think about 2010, so that's impacted call volume. And then you look at 2020 here, the last bar where we're just below 10,000 total calls, and Wisconsin is not unique in seeing a dip in calls in 2020. You know, the CDC is estimating that about quit lines across the country have seen a decrease about 25% in utilization in 2020, likely due to COVID. And the second graph is kind of busy and small, but I just thought it was interesting to look at the varying methods of accessing the quit line. You know, those four that I introduced up front. And I only went back to 2010 because it got so busy, but you know, you can clearly see the call or inbound calls have been the majority of you know, accessing the quit line, the method of accessing the quit line. The orange bar is a fax referral. Again, we've been doing that since 2003. And that was pretty steady until about 2016, when near the end of that year, we began e-Referral with a clinical trial research study. And it really took off in the following years. You can see, you know, reaching a high, and this is just total number of referrals of almost 7,000 or 6,500 referrals in 2019. In 2018, the small purple bar is where we started the web enrollment. And then in 2020, you can't even see it, it's so small, but we had 29 text to enroll enrollments in 2020. And you can just see that inbound calls has decreased over the years, where these other methods have kind of closed the gap. Also wanted to give a snapshot of sort of the typical registered tobacco user in 2020. I haven't seen much of a shift year to year in the characteristics of those who register in recent years anyway. So the majority of people who are registering for quitline service are females, so it's about a 60-40 split. 51% are age 51 or older. The tobacco types, of course, not surprisingly, the majority are using cigarettes, but we do also help people with other forms of tobacco, cigar, smokeless tobacco, and we've been tracking e-cigarette use for a number of years now, and it's been pretty steady at around 10 to 12% of all users. Many of these people are dual users of these products, but we do have also, you know, people who only use smokeless tobacco calling or e-cigarettes using the tobacco, but I think it is more rare. Also looking at insurance, this is self-report, but 50% of all registered tobacco users in 2020, and again, this has been pretty consistent, report being a Medicaid member or uninsured. And that's obviously, you know, a priority for us because we want to help the people with the fewest resources. And we also track chronic conditions. So 60% of all registered users report one or more of a variety of chronic conditions that are exacerbated by tobacco. Okay, so I'm going to talk about the Wisconsin Tobacco Quitline services now, and I'll go into more detail about each of these. So the Quick Coach Call is available to anyone aged 13 years of age or older. They have to be a resident of Wisconsin. People 13 years to 17, so adolescents, don't need parental permission to receive that coaching. And anyone who calls can basically get an unlimited number of coaching calls over the course of a quit attempt. And then if there's relapse, they can call back and start over. It's just that it needs to be initiated by the tobacco user. So if they feel they need the help, they can call in and get it from a coach. When somebody first calls, they go through maybe a 5 to 10 minute registration process, collecting demographic contact information, certainly, and also demographic information. And if and then they can be transferred to a quick coach who's going to go through a pretty in-depth assessment, gathering quit history information, level of dependence, and then they're going to help them develop that individualized quit plan and also discuss the 7 FDA-approved medications. And that includes the 2-week starter kit of nicotine replacement therapy, which is available through the Quit line. We offer a single-use therapy, so either the patch, the gum, or the lozenge. And it is provided in conjunction with the phone coaching. So I guess before I mention the web coach feature, which I will get to in another couple slides, but if somebody does just engage online, but they want the medications, they do need to call the Quit line to actually speak to a coach to get a health screening for those medications, eligibility screening, and some decision support around which of those medications would be a good fit. The person also needs to be 18 years of age or older. And that starter kit is provided to anyone once per 12 months, and it is directly mailed to the caller's home. So the web coach can, as I guess just alluded to, it can be with phone coaching or it can be a completely standalone intervention. It's a really interactive site. It features things like tracking your progress with money savings calculators. They can build their quit plans and modify them as they go. They can go to, there's a variety of topics on discussion forums that they can join to chat with other tobacco users. They can choose to receive coaching emails. It's kind of tailored to where the person is at in their quit plan. We have a Spanish language version of Web Coach, and both versions are, there's unlimited access available 24/7. The username and password never expires. And on our website, we do have a brief demonstration of that. And I have the link there. And here's the new feature, which we're really thrilled to roll out, called Text to Quit. It's an interactive texting program. It is with the Quit line. It's currently available to people age 18 to 24 with the potential to enroll that to additional ages in the future. Since it launched in October 2020, we've seen 69 people enroll in the program. And what's really been interesting is that of the people enrolling, about 80% of those are still actively engaged in the texting program. So it doesn't just end after 6 weeks or 12 weeks. Really, as long as the person is engaged, they can continue participating in that program. So they're still sending and receiving keyword text messages. And kind of a standard service offered to all users of the Quit line is the mailed Quit Kit, which includes a really comprehensive quit guide for tobacco users, as well as other supplementary support materials, such as, there's a piece specifically for pregnant women or smokeless tobacco, Spanish speakers, people who have chronic conditions. There's, single page information flyers that go out with that. So it's tailored to the individual. And this is my last slide where I wanted to highlight the American Indian program, which offers additional calls and support. It's really a fantastic benefit. We've had 59 enrollments since it launched in February, and it includes up to 7 calls. So these are proactive calls. So this is where the person may call in initially to log in or to register with the service and start developing their quit plans, but then the Quit line will proactively reach out to that person over the quit attempt up to 6, a total of 7 coaching calls basically. And they receive a 12-week course of NRT that can be a single use if the person chooses, or there's some use exclusion to the other meds, but and it can also be a combination of NRT, so the patch plus the gum or the patch plus the lozenge. And there's a dedicated team of quit coaches for that program that they receive specific training to deliver that culturally appropriate intervention. People who use that program can still access it by calling 1-800-QUIT-NOW. If they identify that they're an American Indian, it would be offered. And we also have a dedicated phone line for that, which is 1-888-7-AI-QUIT. So that concludes my presentation on the Wisconsin Tobacco Quit Line.
Thank you, Kate, for providing all that information and the updates on the new services the Quit Line is providing. So our next presenter is Dr. Hartlaub. And Dr. Hartlaub is a medical director for primary care quality with the Ascension Medical Group in Wisconsin. Dr. Hartlaub was a part of the Tobacco Screening and Cessation Quality Committee that championed the pilot of e-Referral and its adoption system-wide. He is certified in family medicine as well as general preventive medicine and public health. Thanks for being with us today, Dr. Hartlaub, and we'll get you set up with presenter right so you can share your screen.
Thanks, Ellie. And good afternoon, everyone. So let's see. Good. Looks like that's working. So what I'm going to do is take the next 10 or 12 minutes or so and go over how we initiated one of the tools that Kate had just mentioned, which is the e-Referral. It was new then. We sort of adapted it to our EPIC electronic health record. And I'm just going to tell you a little bit about how that experience, sort of how it went and kind of what the data has shown in terms of the referrals to Quit Line. So I'm going to talk about the initial pilot, which is actually the study that Kate had mentioned. And then expanding beyond that, we had to make a decision about whether to expand beyond the pilot, which was initially just 6 clinics. I'm going to talk a little bit about some lessons that we learned with the process, and then some data, again, that goes sort of beyond, it's more recent. Sorry, going the right direction here. I did want to mention that in doing this project, I mean, there've been a few groups that I would consider sort of just world-class academicians and researchers, and UW-CTRI fell into that category. They were really wonderful to work with. Some of the names: Rob Adsett, Ali Gorilla, Dr. Fiore. On the Ascension side, Tracy Dorlack, Diane Lehman, and Jeannie Wagner is some of the people that helped to work on this project. So e-Referral, I think, was actually defined for you, but it's basically fax to quit, but you can access it through the EMR, and it's designed so that the provider can just fairly easily send a referral in the midst of an office visit. And the rest of it was described to you already. The timeline looked like this. So for several years, 2012 to 16, WCTRI worked with what was then Wheaton Healthcare on the fax to quit process. And then in 2016, this pilot started, which was actually a study. It was randomized. 12 clinics were randomized to either continue fax to quit or begin an e-Referral, which had been built into the EPIC EMR. That e-Referral, we made a decision to make a hard stop so that it popped in front of the provider as they were with the patient during a visit, and they needed to do something with it. So they could either dismiss it and not act on it, or they could order the e-Referral, or they could indicate that the patient declined. And then 2018 to 19, we did the expansion, which I'll give you a little bit more information about. But the initial pilot did show, and on the right there is Ascension. So Wheaton became Ascension, Wisconsin. And then you could see there's almost a 4-fold increase in the number of referrals in the clinics that adopted the e-referral as opposed to the fax to quit. So it was successful that way. We did, and I am going to show you, by the way, some sort of what it looked like and how we used it. We did decide to expand because of the success, and it was tolerated by clinicians, even though there was a hard stop. And it counts as screening and counseling for tobacco use, which is good for sort of quality performance measures. And how we did it was we had a 30-minute introduction training at each clinical site that used it, and we promoted it through quality and our internal EPIC newsletters, and expanded to the 75 clinics as indicated. So one of the lessons we learned is that every click is one too many. It's you think of it as being insignificant, but when somebody is already feeling like they have way too many clicks during an office visit, even adding one can lead to some resistance. So initially we had about 5 or 6 clicks, and then we quickly realized that we could do better. So we got it down to 1 or 2, depending on whether the referral was made or not. And one of the ways we reduced the clicks, this is a screen that would show up to the provider, and initially they had to designate what time of the day the patient wanted to be called, and then also whether you gave them information and they agreed to this. So those were some extra clicks in there. And then what we did is made those default. So it would default to any time, which most patients chose. And then yes, because it was implied that you were talking to the patient about it and they were agreeing to it. That's why you're ordering it. And if you wanted to pick a time, you could certainly go in and do that. But otherwise, with one click, it just defaulted to any time. This is what actually it looked like. It popped up in front of the provider. So sometimes when it popped up at the early part of the visit, it would be a extremely inconvenient time. Maybe the patient was having an emotional challenge, they're just in tears, or just telling the provider about something that was very serious, just diagnosed with a serious illness or a family member or something, and it just didn't feel like it was a good time to ask them about quitting smoking. And this did just pop up if they were current smokers. By the way, it wasn't with everybody. So if it was an inconvenient or inappropriate time, really, you could just hit the dismiss button. So with one click, you get rid of it and go on with the visit. So it was minimally invasive that way, intrusive, probably a better word. And then if you did hit the dismiss button, then it goes into a best practice advisory off to the side. So it was still accessible. If you wanted to go back to it, you could. It didn't disappear completely, but it would be off to the side, and then you could do the order. To actually order the e-referral, it was just a couple of clicks. Like I said, there was some default options, and so you just click order and accept. And that would, so it was pretty fast. Really, the more time consuming part was asking the patient if they were ready to quit, and if they wanted some help with it, and then describing the e-referral, the quit line service. If they refused, again, it was just a couple of clicks. Another lesson that we learned is no caller ID largely equals ignore. So when we started to refer patients, we realized that a lot of them were not accepting the call, the great majority, and there was no caller ID that was not possible to put into place at that time. I'm not sure if that has changed, but we weren't able to have that. So even though this was referred and patients knew about it, they would get a number that they didn't recognize and they just ignored it. so they wouldn't answer. So what we did is we asked providers to prep the patients to let them know that they would get a call within 3 days, and it would not say quitline or tobacco or smoking. It would be not identified. And we also asked the providers to let them know that if they did not pick up, a message would be left, so they should watch for that. And then another lesson was path of least resistance is real. I think clinicians not wanting to spend much time on this, but wanting to refer their patients to this resource, they tended to just refer everyone without talking with them, which was not the idea. And so again, we prepped the providers to prep the patients to let them know that they were going to get this call, and what it was for, and make sure that the patients were aware of it and agreed to it rather than just doing it for everyone. So the performance of it, I'm going to show you a couple years worth on the next slide, but some of it, as Kate actually mentioned, showed with some of her data that the first 10 months of 2020 was not good. It was a heck of a time to try to quit smoking. A lot of stress, a lot of things going on. So quitline calls did decrease and cigarette consumption increased during that time. And then this is what our referral counts looked like. You can, if you track along, the blue is 2019, and you can see in May when we went live, there was a big jump in referrals, and it gradually extinguished somewhat, decreased over time, but really decreased when we got into the orange line there, 2020, and then in April started to increase again slowly and came up significantly. I think that is my last slide. So just wanted to give you a flavor of what we did, how we did it, and some of the results. And then I will hang around toward the end if there are any questions.
Thanks, Dr. Hartlaub, for sharing that story of your adoption of electronic referrals and some of the lessons that you've learned. That was very helpful. Just wanted to note, we've also linked the research study that was conducted comparing Facts to Quit to e-Referral, and that will be in the link that we're providing in the chat box where you can access the slides as well. So I'm going to pass it on to our next presenter, Susan Lunson, and I'm actually going to pass it on to my colleague, Chris Hayden, to introduce Susan.
Thank you, Allie. My name is Chris Hayden, and I'm also a Regional Outreach Specialist with UW-CTRI. Our next presenter is Susan Lunston. Susan is a Wellness Education Specialist in the Office of Population Health at Gunderson Health System in La Crosse. She is the coordinator for the Gunderson Health System Tobacco Advisory Council. Susan has also been the contact for the tobacco dependence treatment systems work, including the e-referral study and system rollout at Gunderson Health. Thanks for joining us today, Susan.
Thank you, Chris. Can you guys hear me okay? And are you seeing my PowerPoint?
Yes to both.
All right, great. Thank you. Well, thanks for inviting me today to share our story. I kept my presentation much more informal. So I guess would just like to share what we've been doing here at Gunderson and to give you a little background as well too. So Gunderson, we're a physician-led not-for-profit health system. We're located throughout Western Wisconsin. We actually go into Northeast Iowa and Southern Eastern Minnesota as well too. We're in 22 counties. We do have a referral center with regional hospitals. We have 325 beds, a level 2 trauma and emergency center. We've been named among the top 50 hospitals, placing us in the top 1%. We've also been designated as a Western academic campus for the University of Wisconsin School of Medicine and Public Health. And we're also very pleased to say that we've been environmentally responsible. We were the first health system to achieve energy independence in October of 2014. This is just a quick map that shows where we are located in, again, southwestern Wisconsin, but we also do go into Minnesota and Iowa as well too. We do have our affiliate hospitals listed there as well too. So cover a pretty big territory. Just again, my information there, and if anybody does have questions, certainly reach out to me. I'd be happy to chat. In regards to our experience with the e-referral, I just want to step back and just talk about our relationship with UW-C-Tree. Similar to what Paul had referenced, we've had a working relationship with them for many, many years. I've been here at Gunderson since 2003, and they were on board, and I just stepped right in, and they've been helping us with our systems training. I email them, call them regularly when I have questions. So again, a huge thank you to UW-C-Tree staff. They've been wonderful. So we already had that established working relationship. And then to kind of look at the timelines, similar to what Paul had described, is we started chatting in early 2016 and just kind of, looked at what we had happening at Gunderson. We had recently transitioned to the new version of Epic. And so I did some investigating with our information systems or information technology team and just tried to learn more about, is this a possibility that we could do something like this at Gunderson? I also reached out to our medical champions and to make sure that they were on board with this as well too, and then had some conversations with our administrative directors. We did end up moving forward, so that was a great opportunity for us again to be involved with this. And we did submit project intake. It can be sometimes a lengthy process here at Gunderson. We're a fairly large organization, so to get the necessary approvals was a feat. We needed to go through IRB approval, and we did need to also get the protocol approved as well too. So that happened kind of mid-year, about June. And then we also were doing collection of data, so kind of like pre and post, to look at the number of smokers or tobacco users that we had within the various clinics. We were able to identify clinics that could be involved with the study. Because we have some really small clinics, that took a little time to kind of sort through so that we would have enough numbers and such to participate in the research project. But those clinics were identified and again randomized for either a fax to quit site or to complete as an e-referral. And that happened then in July. We did select our pilot clinic, and that was actually our Whitehall clinic. We were so happy to have them on board, fantastic champions there. And we did do the training then later in the fall, September, and we did go live then with that whole process with the pilot in September, mid-September, September 13th. I did that for a month and then just tried to work out any quirks that we were thinking might be happening or we're observing. And then we did complete the rollout with the identified clinics with fax referral and e-referral and scheduled trainings. It actually worked pretty good to have the scheduled trainings. I tied it in with my ongoing trainings for tobacco dependence treatment here at Gunderson. I meet with teams regularly, typically for an annual training, and it tied really easily into that. So with our nurses, our MA staff, and then we added the providers as well too. So completed those trainings and did that rollout October, November, December of 2016. The study ran for 6 months. And then similar to what Paul had described, we needed to decide as an organization, are we going to continue this? And certainly, yes, we kept those pieces in place for those trained locations. We met with our leadership here at Gunderson, and C-Tree also was part of that to just kind of explain what we learned from the study and what would be a next step. And we too did roll that out on a systems-wide level. We included all primary care locations that we serve, and then we also added identified specialty areas. So like cardiology, pulmonary, and we actually added behavioral health as well too. So it was really great to be able to connect our patients in a variety of ways with the quit line. So just to kind of look at that again, with the whole timelines there. So some considerations, I guess, that are always important is to look at all the staff that this is going to be influencing or affecting. What are the different departments that need to be on board for that? And then again, just having regular communications with leadership. I was always posting information for staff in regards to here's the latest update. And so that kept people in the loop. And again, we did expand that to the entire system. I'm really excited to say that because we serve patients throughout Minnesota and also Iowa, we were able to tap into those state quit lines as well too. So we actually have the ability to refer our patients electronically within any state that we serve. We did Iowa, the rollout in the summer of 2019, and then Minnesota, we recently just finished that this past fall. So really excited to be able, again, to connect our patients to the resources. And then just here at Gunderson, again, we're doing some similar tracking. And we want to be able to, again, kind of look at our connections with our patients. We do have a lofty goal, as Paul had indicated. Again, we've kind of seen a decline with connections for our patients in a variety of capacities there with the different interventions. And we have a 5-year plan, and we do hope, again, to be at 70% of our tobacco using patients being referred to some type of intervention or provided some type of intervention. We do see medications being, again, the most common intervention. And we have a service here at Gunderson. It's called Wellness Coaching. We're not available 24/7, but we do reach out to our patients proactively that our providers refer to us. And then again, we track our state tobacco quit lines as well too. This includes all states that we serve. So again, options for our patients because not one size fits all. So I think that's another thing that we need to be aware of. And this slide represents the different referrals, and patients many times are tapping into more than one resource. And then this was kind of interesting. So here are some stats that our epidemiologist, Brenda Rooney, she's wonderful, had put together along with Cindy Cartman, our business intelligence specialist. Great work here with the data. We did have higher referral rates for females, I think similar to what Kate had shown. So it seems like either females are more accepting of programs, or there might be some other factors there as well too. Average age was about 49.23 for folks that were referred. And then I guess other noteworthy, again, we were pleased to know that we were referring folks that had Medicaid at a higher rate. And then similar to, I guess, other referrals, we did see the most referrals for folks that use or that are smokers or that use cigarettes. So again, just some take-home messages that kind of reverb with me is, again, having options for patients to tap into, knowing that one size does not fit all. And many times, if there's multiple interventions, we're more likely to see success for that patient. And then, as Paul had indicated before too, staying connected with the staff. Regular reminders. We have some providers we regularly see referring, and then other times it's hit and miss. So staying connected on a systems level is really critical to help our staff remember that we've got options to share with our patients and connect them with the various resources. Thank you.
Thank you, Susan, and all our presenters for sharing information about the quit line and integrating electronic referrals to the quit line. In anticipation of your questions about what to do next if you're interested in integrating electronic referrals, we've posted the outreach map and each of the outreach specialists' contact information, as well as how CTRI can assist with next steps. Before we get to your questions, just a reminder that the slides and other resources can be accessed and downloaded from the link in your chat box, as well as a certificate of completion that Amy had mentioned earlier. And also just to note, please allow up to 24 hours because before the website will be updated with the recording of this webinar. Let's just I see we have a few questions, and if you have any questions, feel free to type them in at this point, but we have a few to start with. I think we have one for each of our presenters. So the first question is for Kate. Kate, there was a question about somebody utilizing the quit line. Do they need a doctor's order to get those meds?
Hi, Chris. No, they don't. It's unless they have a medical use exclusion. For example, if they've had a heart attack in 60 days, the quit line would consider that an exclusion for using that medication, but they can do an override process where they can get a signature from their healthcare provider and then still get that medication through the quit line. But as a general rule, we don't need a prescription or a physician order to get the medication.
Great, thank you very much. The next question is for Dr. Hartlaub. If you were to advise a health system that was just beginning the Wisconsin Tobacco Quit Line e-referral process, what would be the one thing you would tell them to prioritize?
Great, thanks. And I saw that was Rob Atzit. So
yes.
Hello, Rob. And I also wanted to quickly mention Dee Oberst is on the participant line, and she I think started after we initially started, but she was very also helpful with this instituting the e-referral and rolling it out. So what I would suggest is the prepping of the patients. I think it's too easy to mention it on the fly when we're busy juggling about 10 things in the office visit, and so really making sure that they know what is going to happen and why, and that this is a beneficial resource for them. Just to be very direct about it, I think is probably the main thing that I would do to get the most impact, because we saw that did make a difference.
Perfect, thank you very much.
And same question for Susan.
Same for Susan.
Yeah. Yeah, similar to
Sue, I don't think we can hear you very well.
Okay, I'm unmuted.
You're unmuted. Can you speak up just a little bit, please?
Sure.
I think we've lost your volume. Try again, please.
It says that I'm unmuted.
No, we're not hearing you.
Susan, you just sound a little far away from your mic, so I don't know if something is either covering the microphone.
Does this help any better?
Yes, absolutely.
Okay, all right.
Perfect.
Sure. So similar to what Paul had indicated, again, just helping the providers know what the quit line is, referring them to that, and then identifying your champions and staying in regular communication with them. Staff turnover happens, unfortunately, and so that is a challenge in a bigger system. But yeah, just maintaining those connections. It also did help as part of, and this was included in the study, and we included it in the rollout as well too, to help the patient remember. Paul alluded to, the no caller ID that we included in the after visit summary with a dot phrase for patients that were referred to the quit line, that to expect that call, and it may look like this, or it may not show who's calling, and so I think having that information with the patient in the after visit summary was also helpful in reinforcing the service.
Great, thank you. Another question that came up, and it again for Dr. Hartlaub and Susan. Dr. Hartlaub, if you want to go first, is just generally, what are the lessons learned from the integration of e-referral?
I think other than what I had mentioned about really needing to minimize clicks and make sure that the patient knew what was going to happen, I think the lesson learned is that it works. It It can be very annoying when you're starting a visit to have this pop up and you have to do something about it right then. But man, that really, with very few clicks and hopefully just a brief conversation with the patient, you get referrals done. And we know that those work. We know that the quit line works, increases the risk of quitting successfully, the chances. And we know that the nicotine replacement that they offer also adds chance for success. So I think that's a big lesson learned, that this is a system that's fairly efficient. It's slightly intrusive, but it's worth it.
Great, thank you. Susan, anything to share about lessons learned?
Sure. Similar again to what Paul had indicated, ditto that. We also did discover, again, with that BPA firing and that hard stop that he described, must be something that is kind of difficult for providers to deal with, but we ended up needing to include a defer button so that with our process, the MA would room the patient and it would start with the MA. She'd ask the question, he or she would ask the questions, and then the order would be pended, and then the provider would continue the conversation when he would come in during the clinic visit. And they were discovering that that was a challenge if the provider wanted to review the chart before they went in to see the patient. So that defer button was something necessary to help with the workflow that it challenged. So that was probably a lesson learned there to kind of be aware of workflow and what might be impacting that.
Perfect, thank you. Another question for both of you. What are the refractory issues in the various cohort categories to accepting a referral and completion of the program?
Sue, would you
Dr.
like to?
Hartlaub? Or Susan, either one of you can go first, sure.
You want to go first, Sue?
You can go first, Paul, that's fine.
Okay. Really, I guess I can only guess at it. I'm not sure what the factors were that that tended to have them actually accept and follow through on the service, the call. I could only sort of guess at it, but I can tell you that there were many that didn't. The majority didn't, and I think my guess is it's because, you know, if they're in seeing their healthcare provider they're saying what they think their healthcare provider wants to hear, and maybe they think about it afterwards and think, well, I'm really not ready, and so the easiest thing to do is just not answer the call. That's my guess. There may be others who have more actual data and information on that, but some people were just seemed really ready to quit, and my guess is those are the ones that did follow through.
Great, thank you. Susan, anything to add?
Sure. As far as I know, we haven't looked that specifically at our data on our end on the backside for specific patient referrals. But that is a really good question. I would think there's probably a variety of factors there that, yeah, sometimes, you know, the patient being seen might just want to, you know, yep, I'll do that because that's what the provider is maybe asking. I always really stress the importance of you know, having a conversation, meeting where the patient where they're at versus having that patient say what the provider maybe, you know, wants to hear. So there's probably a variety, I think, of factors in there, but yeah, we haven't really looked at the data that closely. So that's a really good question.
Thank you, Susan.